Hello, and welcome to day 2 of the 10th Annual Symposium on Global Cancer Research. For those who were not with us yesterday, I'm Karina Mushro from the University of California, Los Angeles. I'm pleased to co-host this event with my colleague, Dr. Sam Puri from Partners in Hope Malawi, and Dr. Satish Gopal from the National Cancer Institute. Before we get started, just a reminder of some logistics. Next slide, please. As a reminder, attendees will be muted throughout the event. The symposium will be recorded and will be available on the symposium event site. If you have any audio or video issues, you can refer to the Zoom Help Center. The link is on this slide. If you're seeing this slide but not hearing anything, please check your audio settings. You may connect to audio via computer, or you can dial into the session using local numbers provided in the webinar information emailed to you. If you have any questions, please submit them via the Q&A box. Next slide, please. During the scientific panel discussion, the facilitators will post questions via Mentimeter on the Zoom screen. You can open a browser window on your computer or your phone and type in www.menti.com. There will be a code displayed on the Zoom screen, which you can enter into the website, click submit, and you'll have the opportunity to respond to questions, and responses, which are anonymous, will be summarized and appear on the Zoom screen together with all the other responses. Next slide, please. Also, we encourage you to join us on Twitter. You can follow the NCI Center for Global Health at NCI Global Health, and you can engage with us on Twitter during the ASGCR using hashtag ASGCR22 or ASGCR. Over to you, Sam.
So thank you, Karina. And as I said, I'm Sam Puri from Partners in Hope in Malawi. If you were unable to attend day 1 of the symposium, look out for the link to recording in the coming weeks so you can catch up on the proceedings. Here are the highlights of what we will cover in day 2 of the symposium today. After this opening, we will go straight into the scientific panel, which is focusing on rethinking academic global cancer research. And we have a stellar composition of panelists on this panel. After that, we are going to have the meet the abstract authors. This is an interactive poster session, and we encourage you to join this. At the end, we're going to have the Rachel Kellan Award presentation and the keynote address. Then, finally, we'll be able to have a closing remark, which is going to be coming from Dr. Satish Gopal from the National Cancer Institute. With that, I now pass on to Dr. Satish Gopal to introduce the chair of today's panel. Thank you. Satish, over to you.
Great, thanks so much, Sam and Karina. It's a tremendous honor as people are continuing to join from all around the world to introduce Professor Agnes Binigwaho, who will be moderating our morning session. She doesn't require probably a lot of introduction for this group, and of course, introducing her briefly is quite a challenge, but let me try. So Prof. Binigwaho is the Vice Chancellor and co-founded the University of Global Health Equity in 2015, which is a Rwandan initiative of Partners in Health. She's a Rwandan pediatrician who returned to Rwanda in the late 1990s and worked for 20 years in the public health sector. First as a clinician in public hospitals. Afterwards, she worked in various high-level government positions between 2002 and 2016. She served first as the Executive Secretary of Rwanda's National AIDS Control Commission, then as the Permanent Secretary of the Ministry of Health, and lastly, as the Minister of Health for 5 years. She also serves as Professor of Pediatrics at UGHE, Senior Lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, and as an Adjunct Clinical Professor of Pediatrics at Dartmouth's Geisel School of Medicine. She's a member of multiple editorial, advisory, and directors boards, including the Rockefeller Foundation Board of Trustees and the African Union Commission on African COVID-19 Response. She's a member of the US National Academy of Medicine and the World Academy of Sciences, and a fellow of the African Academy of Sciences. She's published more than 230 peer-reviewed articles and was named among the 100 most influential African women for 2020 and 2021. So let me again express my gratitude on behalf of the National Cancer Institute to you, Prof. Binagwaho, for moderating this morning's session, and over to you.
Thank you for this kind introduction. And good morning or good afternoon to everyone joining us from different parts of the world. It is my great pleasure to moderate this panel on rethinking academic global cancer research. This year, the overall theme of the conference is New Models for Global Cancer Research, Training and Control. And this specific panel will focus on academic global cancer research approach with an emphasis on career tracks, research, infrastructure, and sustainable capacity building for global cancer research. This panel will also focus on how we conduct ourselves in the field. Before to go to the discussion, I would like to set the scene on some of the challenges that we face in academic research. Let's go to the next slide. You can pass that one as well. So over the past few decades, we have seen a growth in North-South research partnership. These partnerships were aimed, are still aimed, to sharing knowledge and expertise and provide opportunities for increase the number of researchers in health science as there is a shortage of skilled clinical and non-clinical health professionals in the global south. For instance, in Africa, we represent 12.5% of the world population, but only contribute to 1% of the total global research input. There is an imbalance there. This is partially because of the limited availability of funding in the developing world for research and the few numbers of universities in the developing world. This partnership between North and South could allow for a focus on issues that are related and relevant to the global health issues in the South if this partnership could allow the research in low and middle-income countries to express their needs and work on research that fulfill them. However, despite this need of North-South partnership, there is various limitations. Academic institutions and researchers from the global South are often required by Western development partners to have a global North partners as the lead investigator, suggesting that researchers from the South are not competent. Moreover, there are significant power imbalance. Execution of the research project and the area of investigation are often determined by the global North partners, leading to research that does not address the needs, always the needs of the South. Funding are also managed by the global North partners, despite the fact that some programs are executed in the global South and essentially by low and middle-income countries experts. This is a colonialist practice that fueled the mindset that individual and organizations in the global South are incapable of leading their own project. So this is a limitation of those partnerships. It is not new to many that research funding to the South is used as a powerful tool for power dynamic. Funders practice conditionalities and vertical funds that limit countries to do the research they need, but also to build the research infrastructure and the health sector that they need for sustainability and resilience. So call for research application in the global North is dictated by area that researchers in the global North want, not those needed by the low and middle-income countries. So this interest often doesn't align, and this is another limitation. Next slide. Additionally, there is various ethical challenges in health research. For instance, we see that high-income countries researchers working in low and mid-income countries are paid more for the same service rendered and the same work done than their counterpart in low and mid-income country. And imagine if an expert in a low and mid-income country is paid 50% of a research in high-income country for the same work. What does it mean? That means that for 50% of his time is considered as a slave because it's an unpaid work. These issues exist also in publication, as you can see here. In a study done a couple of years ago, 6.5 publication in General Medical Journal had no co-authors from 90% of the world population. So those are other limitations. So a contributor to inequities in research conception, participation, and dissemination is the lack of sufficient quality research institutions in the developing world. Here, I want to bring up 3 issues. First, we need to keep in mind that the issue is systemic. Africa is a continent of 1.4 billion people, for example. It has only 168 medical schools, where the US, home of 300 million people, have more medical schools, 173. We also look at India, which has a population similar size as Africa, but has 304 medical schools. So the problems are not similar in all the continents, and there is gap to fulfill that are more acute in some continents. Second, we need to foster low and mid-income countries collaboration, creating mentorship and training opportunity. It will be beneficial to capacity development, especially given the challenges faced. Lastly, we need to provide the opportunity for low and mid-income country researchers to work within their own country by increasing the research output, but also the outcome and the way they live with the research, so they don't feel necessary to migrate to the north. In order to ensure sustainable capacity building, we need to fix the leaking pipeline. And you can see that as from the graph on the right, that the scientific field in general, but in health sector in particular, and for women in particular, there is a linking all along the way, and very few reach the level of high researchers and to be capable to live with this. So we need to do so to solve those problems if we want to address the critical challenges that we face on the African continent, for example, and also worldwide. There is a lack, no place in the world have enough health professionals and researchers, but there are some parts of the world that are more underserved than others. So those are some of the challenge, not all of the challenge. Thank you. And I want now to introduce the panelists who will discuss more in depth these challenges and others, taking example of their day-to-day work and propose to us potential solutions to address these challenges. We are honored to be joined by Dr. Nelly Mugo. She is the Chief Research Officer for the Center of Clinical Research at the Kenya Medical Research Institute. Dr. Nelly is also a Kenya Research Associate Professor in the Department of Global Health at the University of Washington in the US. Dear Dr. Nelly, you are welcome.
Thank you. Thank you very much, Professor Binagwaho. I really, really appreciate, oh, I hope I'm not losing my stream. I really, really appreciate that introduction. And I think you've really hit the ball on the head. Thank you.
Thank you, Dr. Nelly. On our panel today, we also have Dr. Andrea Lera, the group leaders of translational genomics at the Instituto Leloir-CONICET Fundación Instituto Leloir from Argentina. Sorry to have misspelled some of the words. Welcome, Dr. Andrea.
Well, thank you. And never mind the spelling. It's a pleasure to be here in this panel. I'm thrilled of the topics that we are going to speak about.
We are also privileged to have Professor Fang Zhao, the director of the Department of Cancer Epidemiology at the Chinese Academy of Medical Science, Cancer Hospital and National Cancer Center in China. Dear Dr. Zhao, you are welcome.
Okay, thank you. Yes, my great honor and pleased to be on the panelist and learn from our colleagues worldwide. Thank you very much for the opportunities.
Thank you, Professor Zhao. Our next panelist is Dr. Doraija Prabhakaran, the Vice President and Director of the Center for Control of Chronic Conditions at the Public Health Foundation in India. Dear Dr. Doraija, you're if he's not yet on the panel, I'm going to introduce you Dr. Oliver Bogler. Dr. Oliver is the director of the Center for Cancer Training from the National Cancer Institute in the US. Join me to welcome Dr. Oliver.
Thank you very much.
I would like to ask you some question on your view on rethinking academic global cancer research. My first question goes to you, Dr. Nelly. Given your experience with the Center for Clinical Research at the Kenya Medical Research Institute, where does Africa stand in terms of its readiness for running large-scale cancer clinical trials?
Thank you. Thank you for that question. I've always wanted somebody to ask me to run a large clinical trial on cervical cancer. I feel pretty ready to do that. So, and I'm sure we have other people on the continent in similar positions. I think one of the things that's been clear to me is that we have a huge body of specialists, clinical specialists in cancer. And because it's such a wide field in different specialties, there are more in some, I mean, there's diversity in access by country and by the type of cancer and the organ, of course, and the group of people. So when it comes to my own institution, it would depend on which cancers. So, but what would make us more prepared? And when I saw this question, my mind went to the HIV field, because the HIV field has been extremely successful in setting up centers, excellent centers for clinical trial research. But what has it taken to set up those centers? One is access to resources, to set up the center and the infrastructure. And I kept thinking there are ways we can marry that, the resources, because some of the resources needed are similar across disease, others are specific to cancer. But when you look for funding for doing your cancer research, it's usually harder to find. It's really hard to find, and most of it is not targeted to us in the African continent, and our own countries haven't set up resources to do this work. So I think the question in terms of readiness, we have the personnel, we have part of the resources, but we need a lot more investment in infrastructure and perhaps the setting up of networks. I'll try not to take too much time.
Thank you, Dr. Nelly. So we need more infrastructure to be really ready. Dr. Andrea, the next question is for you. We have seen evidence of inequitable partnership between institutions and research in the global north and those in the global south. How did you approach this challenge, And what do you advise to other emerging oncology scientists working on collaborative projects? The floor is yours. You are on mute.
Yeah, sorry. Well, thank you for the introduction, and I will speak about my experience for the last 12 years. I have been working in cancer genomics research in Argentina, and I'm executive manager of the Latin American Cancer Research Network, which has recently published the first 2 papers on the characterization of more than 1,000 breast cancer patients at the clinical, molecular, and epidemiological level. This is the so-called molecular profile of breast cancer study. This project was funded by CUGH and local health and research institutions of Argentina, Brazil, Chile, Mexico, and Uruguay, and rendered great achievements, but through a quite bumpy road. I can speak about many aspects of this project, but I will focus on the positive one that I valued most. This was a unique project in that CUGH acted more as a sponsor and trainer of our own capacities than as a partner. And this was a great empowering model involving all the local players, oncologists, pathologists, data scientists, epidemiologists, and health center authorities. And it was in the design from scratch of a comprehensive clinical study. The empowerment of local investigators, although slow and sometimes hectic and expensive in time and resources, led us to success in achieving one of the most complex data sets in breast cancer that, although not perfect, has the potential of growing still further. In my experience, building and sustaining local scientific capabilities is essential, not only for equitable, but also for useful research. Tolerance to the slowness and apparent inefficiency of the programs or projects is essential, as local researchers have to deal with high entropies in our countries, but they are also the only ones that can understand this hectic environment and build bridges to overcome difficulties. One of the lessons learned in Lacron, for example, is that money should probably not be allocated to government-managed institutions or big hospitals, but to smaller institutes with good and transparent financial records that have the possibility of taking care of the expenses of bureaucratic systems in a simpler and more efficient way.
I'm the one. Yes, thank you, Dr. Andrea. You have started giving us quite solutions that you have experienced in your day-to-day work. Dear Professor Nzao, we know that in 2020, China counted 24% of newly diagnosed cases and 30% of the cancer-related deaths globally. What do we know about the epidemiology of cancer in China, and how has it changed over the past few decades?
Okay, thank you very much for the questions. According to the Global Can 2020, there's over 4.5 million new cases and 3 million deaths in China. And both the cancer cases and deaths, the proportion, I think, is much higher than the proportion of China's population in the global population. So that means, you know, the risk is quite high. And the worst things, we see both the incidence and the mortalities have been increasing during the past few decades, particularly for the risk in the men, significantly higher than the women. And President, I think the standardized the incidence and mortality of the lung cancer, colorectal cancer, and the esophageal cancer in China are much higher than those in the world, in both men and women. And for women, the breast cancer, although a little bit lower incidence, but we're seeing a very rapidly rising rates in the cancer order. And we had some analysis as the emerging economy, the cancer burden in China, I think largely attributed to the infection, such as the H. pylori, hepatitis B virus, human papillomavirus, etc. And also due to the life changes, such as the tobacco use, alcohol, and healthy diet, and the less physical activities, this kind of behavior lifestyle. So I think all of these cancer, I think could be prevented, and also should be prevented through the I think right actions taken in China. So it's over to you.
Thank you. It's a wonderful insight, Professor Nzao. My next question go to you, Dr. Oliver. How can National Cancer Institute training programs better serve the career of early stage investigators in low and mid-income countries?
Thanks very much. Yeah, that's a really interesting question. I think I would probably frame it in two different ways. And I would preface my comment by, of course, just pointing to the fact that we are part of the US federal government, and that imposes certain constraints on what we can and cannot do. We were created by the US Congress. We serve the people of the United States, and the money we get, of course, comes from the tax dollars of of people in the United States. So that imposes some limitations on what we can and cannot fund. So I would say in the first area, we do have, of course, a lot of people from all over the world that come and do research training at the NCI in our intramural program. And we also support people from all over the world that come to US cancer centers to do their training there through our fellowships and grant mechanisms. An increasing proportion of those come from low and middle income countries. And I think we have the opportunity to improve the training we provide those individuals, particularly because many of them do return to their countries and wish to implement what they have learned while they came to the United States when they return home. So that is actually an ongoing conversation that we're having at the Center for Cancer Training. How do we improve? And right now or historically, you could say people have come from other countries. They've learned what they learn in our laboratories and research groups, and then they've returned. But we've never specifically addressed how they can take the learning that they gained in the United States and the barriers that they might face when they return to their country of origin, how they can apply that information. So that's definitely something that we can do better at, and we're beginning to investigate it. And we have the fellows at NCI are beginning to help us with that. So we're working with fellows who've come from LMICs to guide us on that. The other side, I would say, is that my center, which is partnering increasingly with Dr. Gopal's center, the Center for Global Health at NCI, to try and understand what kinds of grant mechanisms we could develop that could support individuals from LMICs and in LMICs. So there are some opportunities there. Dr. Gopal is taking the lead. He is the director of the Center for Global Health, but we are standing beside him to help with training mechanisms. And I do hope that we can have training programs. For example, this is just one of the ideas we're thinking about, where there is a collaboration between a US center and a center in an LMIC. And as part of that collaboration, there's a training component, and trainees from both points in that axis go back and forth, exchange information, learn from each other, and thereby strengthen both the capacity on both ends and the collaboration. So those are areas that we're very interested in and we're actively exploring. And of course, we would like to hear from people who want to build such programs. What should that look like? Thank you.
Great answer, Dr. Oliver. And I'm very pleased to hear that you have seen the problem and that you are reflecting internally with your fellows, your alumni, to see how you can improve. Very good move. Dr. Doraid Raj, welcome. I have presented you, you were not there, so I'm not going to present you again. And I'm going to send to you directly your first question. And it is about your experience from other chronic diseases. What have you seen to be effective ways of building research and clinical trial capacity within the field of oncology? How can existing North-South partnership support capacity building in a sustainable and equitable manner? The floor is yours, Doctor. Go ahead.
Thank you very much, Professor Binagao. I hope I pronounced your name correctly. And my apologies for joining. I was in another meeting and my chance was supposed to come half an hour earlier and it came just now. Anyway, I won't waste your time on that. I'll take the second question first, that how do we build this North-South, build capacity, build North-South partnerships and support capacity in a sustainable and equitable manner? I think the most important thing is the philosophy behind these collaborations. If you look at the philosophy behind work done in the past, it was largely related. I mean, I'm talking about 30, 40 years back. It was largely related to, oh, let's go and help LMIC countries. They have these huge problems and I want to go and help. Or there may be others who would have got a grant and it's easy to work in these countries, so they would go there. But I think more and more we think about it, we are talking about true partnerships. And the benefit of research in LMICs or the joint research that we conduct between high-income countries and low-middle-income countries should benefit both the populations. Otherwise, it's not going to be sustainable. Otherwise, it's not going to be equitable. There has to be bidirectional benefits. I think that's the first point I want to make in terms of sustaining these relationships. The second is the communication. Communication is an important aspect. And on a lighter side, I would give the example of communication with the British, for example. If they say that there's something interesting, that what you're saying is interesting, it means that you're saying something stupid. So you just need to understand that international context of communication. That's a very important aspect. The third area, I think, which can be successful from my perspective is joint mentorship. Mentorship provided jointly by a high-income country researcher and a low-middle-income country researcher, because we bring in different strengths, different philosophies, different cultures, and so there can be cross-pollination. Similarly, we also should pair, if you're sending somebody from, let's say, US to India or from India to US, we need to pair the fellows so that they work on a joint question. I think we should move away from the single focus question to a transdisciplinary mechanism where there is a common question that is asked and there are multiple disciplines that are involved and have to answer. So that's my answer for the second part of the question. In terms of the first part of the question, I think we have to rapidly build capacity of clinicians because they're the ones who are going to conduct these clinical trials and research. So short courses are very popular and they're quite useful for them. The second is help build academic CROs because the commercial CROs are not interested in that kind of training. They're focused on providing that little bit of training in good clinical practice and beyond that they forget. So you actually require to help build these academic CROs, which can actually build capacities within their institutions and beyond. And I think we have to encourage multidisciplinarity. So I'll stop here. I won't take too much of time and I'll come back out for the other questions later.
Thank you, Dr. Dora Iraj. You have also bring on the table some solutions that can be applied immediately. Dr. Nelly, you have talked about the readiness of Africa for running large-scale cancer clinical trials and what is being done on the continent to overcome them. But could you develop that a little bit more, especially have partnerships been able to address some of these challenges?
Yeah, thank you. This was for me, right? You know, we have the AOTIC, which I think mainly has been initiated from Africa because that group recognized this need, the African Consortium of Cancer Organization, and they started up also the biannual conference, which has provided a place for clinical scientists on the continent to present their data. And every time I've been to that meeting, I've found, something to follow up what Dr. Prabhakaran has just said, that most people in cancer are also clinicians. So we need to find a way to bridge them so that they don't lose their clinical work, which they want to continue, and also provide them opportunity for training and build their skills to do the research and do the two concurrently. So how to provide training that suits the kind of people doing cancer work in Africa may be very different from the person doing the cancer work in the US. Of course, the other side of that coin is something that Professor Binagwaho mentioned earlier, and it's to do with income. Very often I found my colleagues have to either go out of pocket, use personal time, and give up income generating opportunities to do research. That the access to be financed and earn an income that can maintain you as a clinician of your expectation while doing research is a deterrent to doing research. So if we can bridge that, and if we can demonstrate and have some champions, that people, role models, and somebody can say, Dr. Ndwega, Dr. somebody else did this, Dr. Njeri did this, and I can see it's working and it's doable, and I want to enumerate the same. I think the other question is this issue of infrastructure for research. So I think one of the things we had earlier, we have people who go and get some training. They come back, they're alone, they have an idea. They don't have a data setup system to support their work when they collect it in the field. They don't have a community group. They don't have the fiscal infrastructure. So, all these bits of infrastructure that create the foundation of good science is a resource very often that the scientists don't find. And I know Dr. Andrea mentioned it earlier about the challenges of working in a system that's not set up for research, and you put your research resources in there. And you want participant reimbursement every day. The money, the turnaround time must be quick, but the system you're putting it in is not prepared. So how do we set up that foundation and that system that can support that work? Whether I'm in a government institution, how do we build that within there because it's sustainable? One of my challenges with small private enterprises is they come and go. As soon as that funding is gone, they're gone. So we need to create a foundation that's sustainable, that outlives the time of your grant, that the next person can find and use. I know I'm talking a lot, but I want to say something about mentorship. And it's also the North-South mentorship, because I think I heard about that. And mentorship is key. I've grown as a scientist because I landed in the hands of good mentors, valued what I brought on the table. And as Africans, what we bring on the table may be different, but it's valuable, and it needs to be valued for its value. In knowing your environmental, knowing the disease, your clinical skills, although you don't have your data skills and your writing skills. So those you need to catch up on and find a place to build them, and a place that respects you for where you are in your career, and you don't feel like you're moving from infancy. And I think that's also reflected in the way you're reimbursed for that work. Your reimbursement reflects whether or not you're valued. And mentorship therefore needs to be balanced and bilateral, and it shouldn't be paternalistic, so that we have an equitable environment and we move away from, the popular, I think, thing that's been recognized now about colonization in global health and research. I have a lot more to say, but I think I've talked for longer than I was supposed to, so I'll stop there.
Already a lot of insight, Dr. Nelly, thank you. Dr. Andrea, how would equitable funding partnership in breast cancer help to balance the cost of research, diagnostic, and treatment with the health expenditure of a poor in a low resource setting?
Okay, I agree on all the facts that my fellow panelists are presenting, because you are talking about each and every thing that is true for Latin America. But particularly for this question, I think that we have to start from the very beginning. And I think that the first investment should be in a very thorough diagnosis of the limitations and failures of all the aspects of cancer control in low middle income countries, because you don't know where to put the money on before doing this diagnosis. In Argentina, for example, 37% of the population attends the public health system, which is managed by national, federal, and local authorities and budget. And this is very hard to get the necessary integration of resources to get a good job done. So a lot of money is spent in duplicate efforts because of poor communication of decision makers, and also spent in sustaining inefficient bureaucracy. And so how to balance the cost of that with research? I think that one of the biggest problems of our countries is the scarcity of reliable data to establish a good starting point for any research or intervention. There are a lot of well-intended attempts to establish registries and databases that are frustrated usually, or at least incomplete, by different reasons. And one of the most powerful reasons is the lack of understanding of what a good registry is and what the actual resources needed to get good registries are. In this line of thought, I was thinking yesterday on the need of some systematic analysis of this noise that we talk about that is present in real world data, and the systems thinking approach could serve to understand the weight of each of the multiple variables that affect the outcome of an intervention, being economic, geographic, cultural, or health issues. Without this baseline, it would be very difficult to realize what money to allocate to which research.
Thank you, Dr. Andrea. I think that I like all the ideas you put all together. A lot will come out of this, is already out of this panel. The next question is for you, Professor Zhao. You have primarily focused your work on screening and early detection of cancer. What do you think that health system can do to balance the need for early detection and prevention with the clear need for treatment and care, what is often declared too expensive in low and mid-income countries? The floor is yours.
Okay, thank you. Thanks for the question. I think in the low and middle-income countries, the treatment equipment and the medicines for the cancer patients with the late stage are the most expensive expense. But the demand seems more urgent than early detection and prevention in the general population. So this is very difficult to balance the needs to both, because I heard a leader, he said, we could not let the patients dying, with cancer. So I have to put all the resources on the patients. But however, if you do not stop, the patients, then you have more, the resources, put in the patients. This is kind of worse cycle. So we have to think about how we can optimize the strategies. Only when you start the investment in the early detection, the prevention, so the situation could be possible change. And also with increasing the coverage of prevention, probably you can save some the health resources. So based on my working experience in China, I think several key issues could be considered to balance the needs. I think the first one, to simplify or optimizing the technologies to reduce the cost of the early detection or prevention, and also the treatment and the care as well. At this, I would like to take the cervical cancer prevention, and for example, we all know it's cervical cancer. We have the screening, the primary screening methods, like from the cytology or via inspection or cytology to HPV testing. but the HPV gene testing has got much higher, sensitive, but expensive at the beginning. But we encourage more industries to simplify their technologies, and then I think it's very successful in China. We have lots of domestic HPV vaccines, HPV testings available, and then the cost dropped, and then they will be able to save some of the screening cost, and then the government willing to invest in these screening and early detection, and then you can see there's less patients with the advanced stage. So, and then also they have very better outcome. So I think that's just one thing. And also for the HPV vaccines, the same. We know it's to prevent the cervical cancer from beginning. I think it's the most effective preventive measures for the cervical cancer. But however, still, the vaccine is quite expensive, and also supply is not enough. So we also highly encourage the industry to produce the vaccines and then validate it, and also encourage them to go through the WHO's pre-qualification, and then they can be benefit more women in the low middle-income countries. And then you have to optimize this. And the second, I think, optimize the strategies, maybe like a point of care, the strategies, and you do not need to put a lot of resources in and chasing people for the screening. So then we'll maybe get one visit and then can help them. This is the second one. And then the third, I think, for the policymakers is a very I think this is a very effective way. So you have to show them the evidence on the cost effectiveness for the cancer prevention or cancer screening to them, and then they will make their will to put our priority in the screening. And for the health system, I think also you can combine this service system to keep the cancer care accessible, like women's cancer. You can combine together, give them the checkup for the cervix and the breast and together. So this is one way. And then I think the fifth, I think, is the capacity building for the professional health providers in the community, and you use them much more than the big hospitals doctors. And then the last, maybe the most important, but not the last, I think that's the health education for the public, make them to seeking early screening, and also have a healthy lifestyle. So I think I have to stop here. There's too much things to mention. Thank you.
Thank you, Professor Zhao, for this comprehensive answer. Dr. Dorai Raj, how best can we leverage partnership, both North-South and South-South, within academia to support research capacity building? What successful example have you seen so far? The floor is yours.
Sorry, I was muted. Thank you for that question. I will relate an experience from the cardiology field. So in 1965, Dr. Jeremiah Stanlow, who passed away recently, was 102 years when he passed away. He and several others said that prevention has not taken priority in cardiovascular diseases, and therefore, and research in prevention needs to be built rapidly. So they decided to collect 40 fellows from across the world, put them together for 10 days. Not only they taught the research methods, but also taught them the art of collaboration. How do you actually handle people who are difficult? How do you develop a questionnaire? And many of those questions which were given during those seminars were actually conducted. In fact, the famous study is called the InterSalt study, which actually identified differences in salt consumption and its relationship to hypertension way back in the 70s. So that's one way of doing it. Subsequent to that, there has been, people have been talking about implementation science. The biggest problem in the LMICs is there's a lot of knowledge, but there is poor implementation of these knowledges. And how do you actually implement programs? How do you scale them up do you make them sustainable? So there are emerging leader programs which are conducted. So that's by the World Art Federation over the last 7 years. That's been quite popular. So they get people to work together, ask a research question, provide them with some small seed funds, and then from that they go on to bigger grants. So that's one way of research capacity building. The other opportunity that is there is the Fogarty International Center program. We have the Fogarty program as well as the Fulbright program, and then there is the R25 grant at NIH, which also helps international fellows to come and work in LMICs like India. So that's a very good program because it again provides a good mentorship. I can relate two examples or two or three, several examples of that, but I can just relate one example of a person who came to India, worked with us for 10 months, and went on to develop his career in quality improvement program. He got a K99 and RO award, and within 4 years of his joining faculty, he's at an RO1. So it's a continuum. So once you have these mentorship programs, it's a continuum for some time, and then they branch off and become leaders on their own. So both at a rapid capacity building level, as well as individual capacity building level, there are several opportunities. I'm not sure what is there in oncology. I'm sure there must be something very similar, but some of these crosstalk would be useful in terms of identifying how to actually build capacity in research. I'll stop here. You're muted.
Myself. I think I'm okay now. Yes. Thank you, Dr. Dorai-Raj. There is a lot to take on with what our dear panelists are sharing with us. Thank you. Dr. Oliver, based on your extensive work globally, what assumptions are ingrained in the US model for cancer research training that may not serve foreign trainees well in their career? How can we build programs that better serve those needs? And this is linked to your first question, where you have said that you are thinking internally already how to change and contact your alumni also to see what they should have loved to be trained of. So the floor is yours, Dr. Oliver.
Thank you very much. I mean, I think in the US, we do believe that the NIH, the National Institutes of Health, we're NCI, we're part of that, have been a tremendous success and engine of scientific discovery and economic growth and progress against disease. But it's also very much like anything, a system, right? And we are beginning and have been for some time now, but we're taking a deeper look at its characteristics and its biases, its nature. For example, there was a paper published a couple of years ago about the relative underrepresentation of African Americans in the grants portfolio at NIH. One of the ideas that was put forward was that may be associated with the thematic areas of research that African Americans focus on when they submit grants. So there's but it's a system. And I think the training is the same. We are training people for the US system, and the US system is characterized by a high economic volume medical delivery system, right? Medical delivery in the United States is a big economic engine. A very rich grant environment. We give many grants, and they are much bigger than grants in most parts of the world, and a very rich technological infrastructure and a lot of people doing research. So that is not necessarily reflective of the environment in all the countries of origin of our trainees. And so that is, I think, that's part of the reason they come to the US, but it does limit to an extent, I imagine, what they can then take with them when they return. And I guess my comment from my extensive travels, in a previous role built partnerships between a US cancer center and 30, 40 centers across the globe. I think the local needs, and I think you said this, Prof. Benoit, the local needs and the local priorities should determine what is done. And so in that sense, I don't think we have the answers in the US, but we must do more listening even to the people who come to us for training. I would say to Dr. Mugo, I mean, some of the challenges you described a moment ago, we share, right? I mean, the economic draw for clinician investigators to focus entirely on clinical work exists in the United States as well. It typically manifests in the form of student loans, right? A lot of our clinicians start their clinical career with a significant financial burden. So one of the programs we have is a program that helps them manage those loans. We do a loan repayment program, for example, at the NIH. And so why am I saying this? I would say the analysis that you proposed or that you put forward, that is exactly the kind of information that I would recommend you use to build the local environment in the way that works for you, right? So your problems look different from ours. I mean, there are some similarities, but I would encourage the government, if for example, the government wants to have more physicians do academic work, create an economic environment in which that is possible, because those incentives are real. They exist all over the world. So I'll stop here. I mean, so I guess my bottom line recommendation is, build a program you want. Don't necessarily emulate what we're doing. We're still learning. We're still trying to improve our systems. And hope, I hope that many of the countries that are developing their biomedical research infrastructure, and I will do a better job, and we'll build a better system that will leapfrog and avoid some of the pitfalls perhaps that the US has experienced. Thanks.
Thank you, Dr. Oliver. I can see that you have already some plan to propose. We are running a little bit late, so I propose that we start the third part of the panel. What is the group discussion using Mentimeter? Dear panelists, we would love to listen from your brief input in a minute or less than a minute into each of the Mentimeter questions. The audience input is also highly welcome. For the audience, if you can browse menti.com and join through the code projected on your screen and share your opinion. So we will see what the participants think and what the panelists are thinking. So let's start. And the first, you can all read here, and I guess the panelists, you can read that as well? The first, yes. If you all agree on the statement that are there, and we will see what you think about that. So in 1 minute or less, I will start with you, Dr. Oliver.
You want me to say whether it's easy to find an academic cancer research in the country I'm in? Yes.
Yes, and the rest, all of them.
Oh, okay. Funding opportunities are abundant. They're not necessarily easy to get, but they are relatively abundant. Cancer control is still not as much of a priority, I think, in the US as it should be. There is good amount of international collaboration in the United States, and I think that we do have a lot of mentors, though mentoring is still an area we are improving in.
Perfect. What are your views, Dr. Nelly?
It's not easy to pursue an academic cancer research career in my country, and it's really difficult to find cancer research funding opportunities. The cancer research funding available is very thin, though the country has often talked about prioritizing cancer control, but more on clinical rather than research. And all my cancer research collaborators are outside my country, and it's difficult. It's not easy to find support for a cancer research career from where I live.
Thank you. What about your view, Dr. Andrea?
Well, in my country, you have funding available for cancer research, but not for clinical cancer research, which needs very much higher amounts of money. And regarding the easiness of pursuing an academic cancer research, this is easier for people who go to the academia directly, but not for doctors, medical doctors that have to combine medical work with research. This is very, very difficult. They don't have protected time. So it's very difficult to engage doctors for cancer research.
Thank you very much. What about your view, Dr. Dorai Raj?
So thank you. I think given the number of limited academic centers till now, I would presume that academic research is going to be difficult, but I think the best person to answer that maybe in his talk would be Dr. Pramesh, because he would know exactly where we are. But the government is investing in cancer control. And last year there's been a substantial investment, and hopefully the academic cancer research will increase. The funding opportunities are also similarly tied to that investment, and therefore it will improve, I think. The priorities are kind of in line with the burden in the country, like oral cancer, cervical cancer, breast cancer, and lung cancer and colon cancer. So I think that is fine. I often see cancer research collaborators outside my country. I don't think that's true. It may be half and half people work within the country, and opportunistically they would work with outside. I can easily find mentors, and I think across all the disciplines, there's a need for good mentors. In fact, I was going to suggest a mentorship training program. We should think of those. Thank you.
Thank you. Professor Zhao, what are your views?
Okay, yeah. Okay, I will be quick. I think it's right now it's easy to pursue academic cancer research career in China. And then for myself, I think it can easily find the cancer research funding opportunities. But however, I think for the junior or the earliest career people, probably this is difficult. And then also for the cancer research funding available in line with cancer priorities, still not the priorities, I think. And then also for myself, I often seek the cancer research collaborations outside my country, and also can easily find the mentors, to support my cancer research career. I think I have to thank to my previous training and working experience in the National Cancer Institute of the United States, and also World Health Organization, international agency for research on cancer. So that can help me a lot. But I think most of the professional researchers in China, they may not have that kind of lucky. So that's a highlight. I think we have to, if possible, to enhance the communication, collaboration, globally. Okay, that's over.
Thank you, but we just finished on time, and you can see that the often seeking cancer research collaboration outside my country is good. And because we come here from so many places in the world, that shows how much the South-South and North-South partnership are crucial for the work we all do. That's good. Now, the next question is, it's written there. How can funding organization ensure more sustainable research capacity and career track in low and middle income country? And here again, I will start with you, Dr. Oliver.
Yeah, I mean, I think balancing, so I think you do need a competitive peer-reviewed system so that the best science rises to the top and attracts funding. But I think you need to balance that with some stability and continuity in funding. Disruption in funding patterns can be very, very damaging to individual careers and to sustained progress. So I think finding a system that balances that is the biggest challenge.
Thank you. What about your view, Dr. Nelly?
From where I sit, I think if we could set up consortiums and networks to encourage partnerships, then have space for support for early career scientists. and resources to support their work.
Thank you very much. Dr. Andrea, what is your view?
Well, I think that there's a need for sustained support in those cases in which a leader has already proved that he or she can get to objectives and are already trained. So it's necessary to a sustained support. This is the most important thing I would say.
Thank you. Dr. Dorai Raj, what do you think?
I think given that we are talking about funding from a high-income country to a low-middle-income country, the specific examples are available with Fogati system. Specifically funding a program to create a center which becomes sustainable by itself by training a lot of people and obtaining grants. That could be one mechanism of ensuring sustainability. Of course, local funding should be, there should be matching local funding, otherwise it cannot become sustainable. So it's a question of getting international funding and local funding.
Thank you very much. I think many things you have said, it's linked to what the participants are answering. They still have, for the participants, they still have 1 minute to go. So is somebody wanted to add something? Any of you?
Yeah, I think I agree all of these. It's very important. Another thing is like for the strong commitment of the leadership of the organization, no matter if it's national or international. I think that's the key to make this sustainable.
That's good. Of course, after the meeting, all this will be collected and shared with the participant and with the panelists. But it does. Somebody else have something to add?
Yeah, I want to say that we need specific funding for supporting cancer research, targeted funding to support cancer research skill building.
Yes. Yes, Andrea?
I would say that we have to change the minds of our country authorities because it's very difficult to come back from an experience from the north and get inserted in the system. So that's the reason why I keep on saying that we have to try to focus on those who have already overcome those barriers, and that's my comment.
That's your addition. No, it's closed. So we close for us as well. A lot of a good proposal here. But we are reaching the end of this. So I don't believe we can extend, and we are not going to take the last question through this exchange with the panelists. Because we need to close in 2 minutes. And as we conclude this panel, I would like to request each and every one of us to join me to thank our fantastic panelists for the informative insight they shared with us today that will support future development of cancer control plan and also the collaboration between different countries, different continents with really more in a way that it's more productive. We need to collectively focus on extending cancer diagnostic and treatment services to the most vulnerable, including closing the cancer gap. It has been said that data are missing, that cancer registry is not enough used. And this because it is estimated that by 2035, 2/3 of the new cancer diagnoses will occur in developing countries. And this is important, and this is why it is useful to use all your great insight of our great panelists and solution proposed and what is already ongoing, because we need to be prepared to respond to this situation with an equity-centered approach. We will see what will come for the next question, because the public has participated and voted, and even our panelists has contributed to that. So we can see that mentorship, training, funding are the major answer, but you will see how it is in 3 seconds when they will close. As a closing announcement, I want to note that there is a link that has been shared in the chat box. We wish to welcome you all to gather town for the Meet the Author posters sessions. Thank you again, our dear panelists and all the participants. It was a very interesting session. I was so pleased to chair. Your insights are fantastic and very, very promising for the future. And I wish you all a great day ahead.
Thank you so much, Prof. Agnes, for this. Thank you.
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 Good morning again. My name is Franklin Huang, and I'm an assistant professor of medicine at the University of California, San Francisco, and the co-founder of the nonprofit Global Oncology. Today, it's my distinct honor to present the 2022 Rachel Perline Global Cancer Award to Dr. C.S. Pramesh. I would like to begin by recognizing the Perline family, Don, Rachel's father, and Sarah, Rachel's beloved sister. Rachel Perline was a close childhood friend of mine. We grew up together in St. Louis, Missouri, and our lives closely paralleled each other in our careers. Rachel encountered a profound loss early in her life. Her mother died from breast cancer when she was only 13 years old, and this profound loss really set her on her career path. She went on to graduate from Brown University, attend medical school at Tulane, and also receive an MPH there, and then went to NYU for internal medicine residency. She then came to UCSF for her hematology and oncology fellowship, during which time she was diagnosed with and ultimately would pass away from gastric cancer. Our careers closely paralleled each other, and we would often talk about how to fit in the possible careers of global health, oncology, and cancer research. She was extremely passionate about global health and caring for the less fortunate. She was an intrepid and adventurous traveler, working in China and learning Mandarin. And yet she was entirely grounded in her upbringing, in her roots, in her friendships and family. The only person I knew who would call her friends on their birthday without fail. She believed that caring for others was a privilege, and her commitment to her patients was unparalleled. At UCSF, her absence still reverberates to this day. While Rachel faced the adversity of her illness, she was still Rachel, incredibly positive and always wanting others to know how much they meant to her. It's represented best in her own words and smile. We will share a video in the chat that she recorded as her final message to the community, and I encourage all of you to watch it. This award was established in Rachel's memory, and I cannot think of a better way to honor her memory today than to present this year's 2022 Rachel Perline Global Cancer Award to Dr. C.S. Pramesh. Dr. Pramesh is being honored for his commitment and efforts towards reducing inequities in cancer care and making cancer treatment accessible to all geographic regions and strata of society. Dr. Pramesh is the director of Tatum Memorial Hospital. He serves on the UICC Board of Directors and is the convener of the National Cancer Grid, a large network of 266 cancer centers in India. The mandate of the National Cancer Grid is to provide uniform standards of cancer care across the country. His clinical interests include the management of esophageal and lung cancers and minimally invasive surgery. He is the secretary of the Indian Society for Diseases of the Esophagus and Stomach, and he is the principal investigator in several investigator-initiated research studies, including randomized trials on cancer screening, surgical techniques, neoadjuvant and adjuvant treatment of thoracic cancers. His research interests include health services Research Value-Based Care, Addressing Barriers to Access in Cancer Policy, and he has published more than 250 peer-reviewed journal articles, abstracts, and book chapters. He serves on the advisory boards of several prominent national and international research organizations and granting agencies, including ASCO, ESMO, and the UICC. Dr. Ramesh, congratulations on your award, and we look forward to your keynote address today. If you have questions for Dr. Pramesh, please put them in the chat in the Q&A, and we will have a session afterwards for discussion and questions. Dr. Pramesh.
Thank you. Thank you very much for the kind words, Dr. Huang. I'd like to take this opportunity to thank the Rachel Perline Award Committee, as well as the NCI CUGH for this honor. Before I start, I'd just like to take a moment to acknowledge how deeply honored and humbled I feel with this award, in the name of someone who's dedicated her entire life for patients who were treated by her and for global cancer research. And the testimony to the efforts that she took is manifest by the very touching ode to Rachel, which one of her colleagues and very close friends, Dr. Aparna Parikh, made at ASCO Voices last year. And for any of you who have not watched that, I'll strongly urge you to do that as well. What comes across very clearly in her entire interactions with her colleagues, which I learned over the last few days, is her incredible optimism, her sense of cheerfulness, regardless of the fact that she was battling a stage 4 gastric cancer for the larger part of her last a couple of years. I particularly like this picture that was taken very close to when she passed away, where she's fostering or hugging a little pup that was brought home to her just to cheer her up. And the passion and the compassion that she shows in her handling of this pup is incredibly demonstrative of how probably her patients felt when they were being treated by her. So though while she might not be with us today, I strongly believe that her spirit lives in the many people that she's touched and the hearts that she's moved. So over the next few minutes, 20 odd minutes, I'll speak to you about something that is transformed cancer care across the country in India over the last decade, and has largely consumed my life over the last decade as well. So about 10 years back, we had this heat map of 75,000 patients who visited the Tata Memorial Hospital in Mumbai. And for those of you who are as geographically challenged as I am, that's where we are located in the black dot. So this large density of patients that you see in and around Mumbai is probably understandable. But this high density of patients that have come in from northern India, eastern India, and northeast India is something that's very disturbing. And just to give you context, the time it would take for a patient to travel from Naharlagun in Arunachal Pradesh to Mumbai could easily be 2 days, and that's even if you take flights. And the cost of living in Mumbai for the duration of time it takes for a complete cancer treatment to be done can give you kind of a example of how much access and affordability were a challenge for patients in India. Added to this is the increase in the projected cancer burden in India, as in many other low middle income countries, a 70% increase over just 2.5 decades. And it is expected that by 2035, almost 70% of all patients with cancer in the world would be in low middle income countries. We are not known for our public healthcare expenditure. We merely spend 1.5% of our GDP on public healthcare, with the result that almost 3/4 of overall healthcare expenditure is met out of pocket, and just 1/5 by public healthcare funds. And just to give you context, in comparison with the United States has a 17.7% GDP spend on healthcare. The United States has a per capita GDP of over $63,000 US. with the result that every individual in the United States has an average public healthcare expenditure of just over $11,000 US. Compare that to India, where the percentage GDP spend is 1.5%, the per capita GDP is under $2,000, with the result that under $30 is spent per individual on healthcare. Ernst & Young did this report a few years back, where they looked at some metrics which are surrogates of cancer care facilities, the number of linear accelerators, the number of dedicated cancer beds and comprehensive cancer centers. And as you can see, compared to the estimated requirement in 2020, the numbers available at that time were roughly half. And when you go to the specialized human resource required to treat it, whether it's medical, surgical, and radiation oncologists, they are even worse. And the availability was 1/4 of what it was. And again, just to give you context, the Tata Memorial Center is a sister institution of the MD Anderson Cancer Center. We are remarkably similar in many ways. We see almost the same number of patients annually. And while MD Anderson has 1,700 physicians and researchers working for them as permanent faculty, we have 188. So we were faced with this very major dilemma of how to eliminate these disparities, and we needed to look at out-of-the-box solutions and disruptive solutions to answer these questions. So we thought creating a network of existing cancer centers across the country would probably be the best bang for our buck. And we created this 10 years back with the tri-pillared mandate of having uniform standards of cancer care, to develop trained human resource, and be a ready platform for collaborative multicentric cancer research. So 10 years back in August of 2012, we sat in a gloomy room at the Tata Memorial, and out of the 29 regional cancer centers that we invited, the directors of 17 of these centers came together in an effort to try and see whether this initiative was indeed feasible. So one of the first efforts that we took was to have a gap analysis, to look at the existing burden of cancer, to identify what our national priorities in cancer research should be, but most importantly, to look at how we could deliver affordable and equitable cancer care in India. One of the first initiatives that we took was to have evidence-based guidelines for management of common cancers. And we did this in a record time of just over a year and a half. We had several working groups working parallelly and in concert to achieve this. But what we rapidly realized was that evidence was one thing. So this is a graph which shows the median progression-free survival and the median overall survival of 71 consecutive drugs approved by the US FDA based on robust evidence. And as you can see, that the gains in progression-free survival were just 2.2 months, and the gains in overall survival were even worse at just 2 months. And these were consecutive drugs which were approved by the US FDA. And all of this came at a cost. Over the last 50 years, we've had a substantial increase in the costs of cancer drugs that have hit the market. And for those of you who feel that this rather gentle curve is okay, adjusted for inflation, I must point out that the y-axis is on a logarithmic scale and not on a linear scale. So there has been an exponential increase in the cost of cancer drugs which have received FDA approval over the last 50 years. And even by US standards, the cost per quality of many of these drugs ranged anywhere from over $250,000 US at the minimum to well over 1.2 million per quality gained. And just to give you context, even in the United States, what is considered an acceptable threshold for cost per quality is $50,000 to $150,000 US. So clearly, this is not something that is sustainable, even in high-income countries, let alone in low-middle-income countries like India. Along with our colleagues at Queen's University, with Chris Booth and his fellow Joey Del Paggio, we did this study which looked at evaluating what the value frameworks were. And the two best known value frameworks are the ASCO and the ESMO value frameworks. And just to simplify this rather complicated bar graph, what it actually demonstrates is that the ASCO and the ESMO value frameworks just did not agree with each other. Not only did they not agree with each other, there was a cost benefit conundrum. You would expect that as benefit improves, the cost would improve and vice versa. But what we actually saw was a negative correlation between the cost of a drug and the benefit that it accrued, which meant that the lower the benefit, the higher the cost. So with drugs which met the ESMO benefit threshold, the median costs were $8,600 per month, whereas with those which actually met the ESMO benefit threshold, it was just under $3,000 US per month. So towards some baby steps towards our own health technology assessment program, we launched our Choosing Wisely India, which is an effort to identify low value and at times harmful practices that should be avoided in cancer care. And we identified 10 such practices which were very common. And while many of these recommendations, let me just read out a couple of these for just as examples. Do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. Do not delay or avoid palliative care for a patient with metastatic cancer because they are pursuing disease-directed treatment. Though these might seem intuitive to an audience like this, the fact that this needs to be spelled out is testimony to the fact that these are very commonly performed and are either low value or actually harmful for our patients. With the result that we came out with the second version of the guidelines last year, which are online, and these are resource stratified and thus take cost and benefit into the equation while recommending treatment guidelines. We believe strongly in quality and in the fact that low-cost cancer care should not be done at the cost of high quality. So we have several initiatives which look at quality within the National Cancer Grid. We have an institutional peer review which looks at quality of an organization which treats cancer. We have a very robust surgical pathology EQUAS program, and for many of you who are familiar with the College of American Pathologists quality assurance program, anyone who's been through the CAP accreditation, no offense meant, realizes that it's an extremely resource intensive, effort intensive, not to speak very expensive way of getting your pathology department accredited. We go through the CAP accreditation ourselves at Tata Memorial, but we realized that this was out of reach for many of the centers which are members of the National Cancer Grid. So we launched our own leaner and meaner version of the CAP accreditation, which we offer completely free of cost to all member organizations, wherein the quality of pathology reporting is fed back into these organizations and a complete feedback loop is achieved. More recently, we've expanded the scope of the surgical pathology to include molecular pathology and immunohistochemistry as well. And though this is a voluntary effort, several NCG members have volunteered to be part of this EQUAS program. We have expanded the scope of our quality assurance to hospital functioning as well. And we run this NCG. We are a quality improvement hub in India, and we run this quality improvement program for several of the member organizations which are part of the National Cancer Grid. All of us who treat cancer realize the importance of a multidisciplinary approach to treating cancer. However, many of the smaller centers lack the ability to do this. And with the result that several opinions offered at many of the smaller centers are individual opinions rather than MDTs. And we offer an online resource for patients. All that a patient needs to do is to upload his or her medical reports, including DICOM images, scanned slides onto a secure website. The backend of Navya then converts it into a structured format, which is fed into one of the National Cancer Grid experts. And the expert feeds back their online opinion. And everything that I described happens in a median turnaround time of just 24 hours. As I mentioned, the smaller centers lack the ability to have specialty-based tumor boards. So we started this process of virtual tumor boards much before COVID struck us, almost 6 or 7 years back. And so far, we've had over 600 virtual tumor boards, over 3,000 patients who've been complicated problems who've been discussed on these tumor boards. At any given point of time, there are between 100 to 150 oncologists from across the country who log in and offer their expert opinions at fixed times. Leveraging the numbers that we have, we negotiated with journal publishers and are able to get substantial discounts on journal subscriptions as well as subscriptions to books and other library resources, again, which is offered free of cost to all government and academic centers within the National Cancer Grid. We also have a discovery tool which aggregates the resources of the member centers as far as their library holdings are concerned. Again, this is centrally indexed, searchable in a single platform. So anything that is required by any of the member centers is again sent back to them within a median of 24 hours. We have our own massive open online courses on continuing medical education on cancer. And though we initially meant this primarily for cancer, we leveraged the resource to include the recent pandemic and educating the public as well as physicians on best practices as far as COVID, cancer, and COVID with cancer have been concerned. I spoke to you about the challenges of traveling from the northeastern part of India, which is geographically challenging because it's a very hilly terrain and it could easily take up to 6 to 7 hours even to travel 100 kilometers. And therefore, the physicians in the Northeast find it difficult to access continuing medical education resources in the rest of the country in cities like Mumbai, Delhi, and Chennai. So rather than expect them to reach these cities, we flip the entire system around and we send a group of experts from the National Cancer Grid to train pathologists and oncology nurses within these centers on best practices. And we did this over 2 cycles over 26 days. And to those of you who are not familiar with the terrain in the Northeast, this is the equivalent of an Ironman in as far as traveling is concerned. And thanks to this, the overall quality of reporting in pathology as well as reporting in synoptic formats has improved dramatically. Again, based on our experience with negotiating with journal publishers for journals, we were able to get into group negotiation for cancer drugs. What we did was to aggregate and collate demand from multiple centers, pool their volumes, and use a central tendering and negotiation process. However, the final contracts were signed between the individual centers and the pharma companies, giving them independence as far as this was concerned. And we were able to achieve discounts of anywhere from 20%, and these were typically for patented drugs where there was no competition, to up to 80% of discount on MRP where we had generics and biosimilars that were available, thereby lowering the cost of cancer treatment substantially. Coming to research, this was again work done by Chris and his colleagues at Queen's University, which we were happy to partner with. What we looked at was look at close to 700 randomized trials to try and identify whether we had our priorities right as far as cancer research was concerned. And as you can see from this figure on the left, the burden as far as cancer mortality was concerned had nothing to do with the actual trials that were run. So industry prioritized research not based on the actual cancer burden, but more on where they could maximize profits. And out of these 700, close to 700 randomized trials, unsurprisingly, over 90% were led by high-income countries. Close to 90% tested systemic therapies. What it actually means is that surgical trials, radiation trials, trials on palliative care, supportive care, survivorship contributed just 13% of over close to 700 trials that were part of this study. Very surprisingly, those few randomized trials that were conducted in low middle income countries were less likely to be industry funded. That's not so surprising. But what was surprising was the fact that they were more likely to meet their primary endpoint and actually had a larger effect size than randomized trials done from high income countries. Very sadly, in spite of having a higher possibility of meeting the primary endpoint, in spite of having a larger effect size, they had a higher probability of being published in a lower impact factor journal, regardless of whether the trial was positive or negative, clearly demonstrating a substantial publication bias amongst journals as well. Recently, we had the opportunity to contribute to a piece in Nature Medicine where several experts globally contributed to this to try and identify what should research priorities of low middle income countries be. And I'm reminded of the discussion that we had in the previous panel where several of these priorities were discussed. But this is just a month away from being published in press. And the priorities we identified was first, to reduce the burden of advanced stage disease. Second, to improve access, affordability, and outcomes in cancer care. health economics, health technology assessment and value-based care, quality improvement and implementation research, and finally, to leverage technology for cancer control. And again, for an audience like this, while all of these 5 priorities might seem very intuitive, it is fairly disappointing to realize that most modern randomized trials do not involve any of these 5 research priorities. So at the Tata Memorial Hospital, we've had our own research priorities for the last 2 to 3 decades. We've got focused on several cancers, but I'll just take a few examples to demonstrate the approach that we've taken. Oral cancer being very common among Indian men, no effective systemic therapy and outcomes being suboptimal. Cervical cancer, again, a common cancer, used to be the most common cancer in women, now has been overtaken by breast cancer. We realized from Western studies that screening was useful. However, we had a study from the ICMR, which is the Indian Council of Medical Research, which said that the pap smear was not feasible for lack of available cytologists and technicians to be able to interpret them, and the HPV DNA testing was expensive. And finally, with breast cancer, again, the commonest cancer in women, both globally as well as in India, we know that screening is useful. However, population-based mammographic screening is not feasible in a country like India, where we lack the resources as well as the qualified radiologists to be able to interpret them. So 3 common cancers, and I'll let you know how we addressed each of these. With oral cancer, we know that prophylactic neck dissection may or may not be helpful. There was no consensus when the trial was launched about whether prophylactic lymphadenectomy in clinically node-negative oral cancer would be useful. And therefore, we launched a randomized trial comparing an elective neck dissection with a wait-and-watch policy. And what the study showed was a 12.5% absolute improvement in overall survival with elective neck dissection. I challenge you to show me one other intervention that has had such a dramatic response, an absolute response of a difference of 12.5% in overall survival compared to something that takes 45 minutes of additional surgery with practically no resources that are required. The second example I want to share is the screening for cervical cancer. This was a cluster randomized trial. Over 150,000 women in 20 clusters randomized either to screening with visual inspection with acetic acid or health education alone. And what this study showed that there was no overdiagnosis using a VIA. One of the most difficult problems to handle in a screening trial is overdiagnosis. So this demonstrated that there was no overdiagnosis. And what we were able to show was a 31% reduction in cervical cancer mortality with a very simple, effective intervention, which could be done by healthcare workers who were just past their high schooling. Subsequently, subsequent to this randomized trial, and this is where the implementation part of our research is so important, the Ministry of Health started mass screening for cervical cancer in 100 districts in India, and it's likely to get scaled up to all the remaining districts in the next 5 years. And in addition to just doing this, we have launched a blended learning program for training health workers as a Train the Trainers program, which has compressed the learning period from 5 weeks to 2 weeks. The final example I want to show you is of the screening with clinical breast examination, given the challenges of population-based mammographic screening in a country as large and widespread as India. And again, we were able to demonstrate a 30% reduction in breast cancer mortality in women over the age of 50, something very similar to what mammographic screening has shown in this age group. We've just completed, similar to the oral cancer trial, we've completed a surgical trial on more radical versus conventional lymphadenectomy in esophageal cancer, a single center study with 700 patients recruited, which is awaiting follow-up data. I did mention to you about our emphasis on pragmatic implementable research and the AD-aspirin study, which we are conducting in collaboration with the Medical Research Council of the UK, which is a basket trial involving over 9,000 patients in 4 common cancers, breast, colorectal, gastroesophageal, and prostate, aims to answer the question about whether either high dose 300 milligram or low dose 100 milligram aspirin given as adjuvant treatment after radical surgery or chemoradiation for these cancers would improve survival. The National Cancer Grid does fund research projects provided these criteria are met. It needs to be a multicentric collaboration, multicentric, multidisciplinary, We do not fund single center studies. The cancer that is being studied needs to be common or unique to the subcontinent. If it is an interventional trial, it needs to be a cost-effective intervention which can be readily implementable, unlike many of the newer drugs that have come in from high-income countries. Researchers who are funded by the National Cancer Grid have to commit to share their data in the public domain so that other researchers can mine their data after the study is completed to come up with newer findings. And we have a heavy emphasis on public and patient involvement. More recently, we made a systematic effort at identifying gaps in evidence and answering them, and we call this the National Cancer Research Initiative. So these are some of the studies that we have funded, just a sample of them. And as you can see, this would be unimaginable without a collaboration or a consortium the size of the National Cancer Grid. So most ALL studies, acute lymphoblastic leukemia studies, have sample sizes in the range of 300 to 400 patients. Our study, which looks at optimizing management of acute lymphocytic leukemia, has a sample size of 2,240. We look at indigenous solutions like curcumin and metformin. Repurposing drugs is a very major focus. Adjuvant radiation in early head and neck squamous cancers, and very cost-effective and innovative interventions which look at providing implementable, feasible solutions, and all happening in very reasonable funding rates, again demonstrating that it is possibly far more efficient to do large practice-changing clinical trials in low-middle-income countries than it is in high-income countries. Realizing the pain points that many researchers have, and this came across very strongly in the last panel that we had, the lack of protected time and the lack of resources to support them, we've started a clinical trials unit and a contract research organization which helps researchers in the nuts and bolts of doing studies, study designs, statistics, regulatory submissions, and so on, and with monitoring as well. The Credo workshop has been one of our big success stories. So there are, it's an intensive workshop which is aimed at training early career researchers on the methods of clinical research, and we've been doing this over the last 7 years now, except for last year when we had to stop it, when we had to not run the program because of the COVID pandemic. And what this workshop actually means is that participants come in with a one-page research summary, which is a vague idea at the back of their mind, and over the period of 6 very intensive days, call it a boot camp for research methods development, come out with a full-fledged research protocol which is ready for ethics submission. And just to give you an idea of scale, we run this typically with just over 60 participants, for which we have 35 faculty, a very high faculty to participant ratio. And this is one of the key programs which the National Cancer Institute Center for Global Health has supported over the last 4 or 5 years. And we're very, very grateful to them for having done that. Again, this is one of just 4 such workshops worldwide, the other 3 being in California, Europe, and Sydney. And this is the only one of its kind which is conducted in a low middle income country. Based on feedback from Credo participants, we support them and continue to mentor them using our virtual research boards. And this is ongoing mentoring as their research protocols get developed over their careers as well. We believe strongly in working and collaborating with the government. This is an MOU that we signed with the Department of Biotechnology, which is a very ambitious program looking at funding cancer research across the country. We also partner with Ayushman Bharat, which is the largest publicly funded insurance scheme in the world. It covers 500 million of India's population, the bottom 40% of India's population, socioeconomically. And we partner with them not just on working with them on rationalizing their tariffs, but also link our resource stratified guidelines to reimbursement under the scheme. So if you don't follow the National Cancer Grid guidelines, you don't get reimbursed under the Ayushman Bharat scheme, which is a fairly innovative way of ensuring that quality standards are met while treating patients with cancer. Based on requests from several other low middle income countries, we launched the Center for Global Health equivalent of the National Cancer Grid, and several countries and hospitals have been part of this. And we are expecting that the best practices that we have been able to establish are actually passed on to many of these countries as well. And we'd be happy to partner with the NCI Center for Global Health on this. These are some of our future steps. Integrated data collection, we realize the strength that we have in numbers, also lending itself to creating a very robust rare cancer and exceptional responder registry. We are in the process of applying for funding for this, and we look forward to organizations which are happy to fund this. Going on with our success with group negotiation for drugs, we are extending this to equipment like PET CT scans, linear accelerators, CT scans, MRI equipment, and so on. And finally, launching a very ambitious program on health technology assessment, which will feed into our resource stratified guidelines. An effort of this magnitude would not be possible without the unstinting support of several national and global organizations, many of whom are represented in this graph. And I'll take this opportunity and this forum to express my deep sense of gratitude on behalf of the National Cancer Grid for their unflinching support to everything that we've tried to achieve over the last 10 years. So I mentioned at the beginning of my talk that we had 17 skeptical directors of regional cancer centers being part of our meeting to launch this initiative 10 years back. And I'm happy to say that 10 years later, we've grown to 260 plus cancer centers. We've expanded the scope to include research institutions, patient groups, professional societies, and charitable organizations, which, as you can see, fill the breadth and length of this country. And between these centers, over 750,000 new patients with cancer are treated annually, which is approximately 60% of all of India's cancer burden. Thank you very much for your attention, and I'm happy to take any questions that might be there.
Thank you, Dr. Pramesh. The phenomenal address and a really impressive amount of work that has taken place in the National Cancer Grid. We do have a couple minutes for questions. A question in the Q&A asks, what were the most important factors that guided your successes? Can you comment on how you achieved consensus and collaboration in the National Cancer Grid?
That's a great question. And I think the entire success, not just for the consensus part of it, is the fact that we have a very flat system. It's a completely non-hierarchical system. And all centers, all member organizations are equal, regardless of their size, their magnitude, their stature, whatever they might contribute. And to me, this democratic way of running this organization has been extremely key to the success of this organization. When we started off, we were at risk of being considered Big Brother. The Tata Memorial Center, by virtue of being the largest and the oldest cancer center, ran this risk. But we've been able to ensure that all centers have their voices heard. And to be honest, many of the initiatives that we've launched have actually originated from the smaller centers. The hunger for improvement, the hunger for quality has really driven this approach much more than anything else.
Great. I think we have just 1 minute left. So I think there are a couple of questions still in the Q&A, but I think that we will have to answer those offline, if you don't mind, Dr. Pramesh, so that we can turn it over to Dr. Gopal to close the session. But congratulations again, and thank you so much for all of the impressive work on behalf of you and your colleagues. We're quite honored to have you speak to us today, and I think I can speak on behalf of at least my understanding is that we've learned a lot in very inspiring work that you've done in India. So thank you very much and congratulations. And now I'll turn it over to Dr. Satish Gopal, Director of the National Cancer Institute Center for Global Health.
Great. Thanks so much, Dr. Huang, for that really moving tribute about Dr. Perline, who we have the opportunity to still think about, I think, on a regular basis. And congratulations, Dr. Pramesh. I think every time we have the opportunity to hear about the National Cancer Grid, we're really amazed at what you all have accomplished within such a short period. And hopefully the best tribute to Dr. Perline is the type of work that you are doing, and many of those who have attended this meeting I think oriented around many of the same values by which Dr. Perline lived her life. So it falls to me to try to close the meeting. And so I want to start by first thanking the Scientific Steering Committee. I think a couple of slides later, we have again a reminder about the many organizations that have participated in this meeting, and they are reflected in the steering committee membership as well. It's an immense amount of work to put together a meeting like this that tries to include people all around the world in various time zones and speak to the diversity of interests in the global cancer research and control community. I think Professor Agnes Binigwaho this morning described this morning's session as a sprint. To me, this entire meeting has been a sprint, and I really want to thank all of the members shown on this slide for all of their work in putting, I think, a really exciting and interesting agenda together. Next slide, please. There is a post-symposium survey, and let me entreat you all to complete this even more than perhaps we usually do at the end of meetings. We have really been trying to actively evolve ASGCR over the last couple of years, embracing the COVID-imposed virtual format, and we have a real interest in building a cancer meeting that is unique in the landscape of scientific meetings focused on either global health or cancer research. We would really like to figure out ways to optimally engage and include people involved in cancer research and control all around the world, no matter where they live. We think that's part of our obligation as the United States National Cancer Institute. So we've tried many new things this year, including the GatherTown platform for viewing scientific posters and interacting with the authors. We would love your feedback on how this meeting has gone, and in particular, things that we might think about as we start to plan next year's meeting. We have actually several meetings set up over the next several weeks to debrief about this year's meeting and start thinking about next year. So any advice that you all would have for us, I think would be deeply appreciated. Next slide, please. This again is the partner organizations that we have the honor of working with each year at the National Cancer Institute to try to put this event together, including longstanding partners like AACR, ASCO, the Consortium of Universities for Global Health. For those of you attending the CUGH main meeting, I also am looking forward to that and hope you all enjoy the main meeting as well. In addition to many of the NCI designated cancer centers and their LMIC institutional partners who are doing amazing work out in the cancer center community. Next slide, please. So I want to end where we started. I don't know if all of you were with us on day one yesterday morning when we started. I do like symmetry. And so I'm going to end just as we began, which is just remembering that I think someone who's probably been an enormous influence for all of us and certainly for the field that we're all working in. Paul Farmer died recently, and that's an enormous loss, I think, to the global cancer research and the global health community. So I want to remind people of something that he often said. I think this has been very highly reflected in the work that's been presented during these 2 days, including the session we just heard about Dr. Perline's life and the work that Dr. Pramesh has led in India over the last decade, which is the idea that some lives matter less is the root of all that is wrong with the world. I also mentioned yesterday that Professor Binigwaho, who was kind enough to join us and moderate this morning's session, in a tribute to Paul Farmer, wrote that the best way to honor his memory will be for all of us to stand stronger together, doing what he loved most, which is fighting poverty and disease, promoting human dignity with a focus on the most vulnerable and promoting equity. These are values that we are very much trying to internalize at the NCI. I think, again, these values have been reflected in much of the work that's been presented and even the design of this meeting. And so I encourage us all to continue working on doing the things that we're doing oriented around these values, and really look forward to seeing all of you again next year and also in the intervening year at various fora and through various collaborations and networks. Next slide, please. So thanks again. I think with that, I want to thank you all for attending. Look forward to your advice about how to make this meeting even better next year. And we'll officially close the meeting and look forward to seeing all of you again next year. Thanks again, and thanks to all of the organizing members and institutions.